Good afternoon, and welcome to the City Club of Cleveland. My name is Paul Harris, and I am president of the City Club's Board of Directors. I am pleased to introduce today's speaker, Dr. Kenneth Thorpe, Robert W. Woodruff Professor and Chair of the Department of Health Policy and Management in the Rollins School of Public Health at Emory University in Atlanta, Georgia. Dr. Thorpe is a leader in the effort to combat chronic disease and to understand and assess related health care implications. He earned his undergraduate degree from the University of Michigan, his master's degree from Duke University, and his doctorate from the Rand Graduate Institute. Prior to his positions at Emory University, he held health-related faculty positions at Tulane University, the University of North Carolina at Chapel Hill, Harvard University, and Columbia University. He has also held visiting faculty positions at Pepperdine University and Duke University. Dr. Thorpe has received a number of awards for his work in academia. In 1991, he was awarded the Association for Health Services Research's Young Investigator Award, presented to the most promising health services researcher in the country under the age of 40. He received the Hettleman Award for academic and scholarly research at the University of North Carolina and Modern Healthcare's Up-and-Comers Award. Dr. Thorpe has frequently testified before congressional committees on health care reform and insurance issues. From 1993 to 1995, he served as Deputy Assistant Secretary for Health Policy in the United States Department of Health and Human Services. In that role, he coordinated all financial estimates and program impacts of President Clinton's proposed health care reform. Dr. Thorpe also directed the Clinton administration's health care reform estimation efforts in dealing with the 103rd and 104th congressional sessions. Dr. Thorpe has authored and co-authored over 100 articles, book chapters, and books, and is a frequent national presenter on issues of healthcare financing, insurance, and healthcare reform. He has worked with numerous groups and policymakers, including a number of United States senators, to develop and evaluate alternative approaches for providing health insurance to the uninsured. He also serves as a reviewer on several healthcare journals. Dr. Thorpe's remarks today are timely as healthcare reform and its costs and impacts continue to be at the forefront of the nation's agenda, in particular, I think, the post-election agenda. I am pleased to present on behalf of the City Club of Cleveland, Dr. Kenneth Thorpe, Professor and Department Chair at the Rollins School of Public Health of Emory University.
Well, thanks, Paul, for that overly kind and generous introduction. That's actually the one that my mom wrote for me, so she likes that particular version of it. I also want to thank the City Club for inviting me, the Murphy family for sponsoring the lectureship, and Progressive and other sponsors who also contributed to this. So it's a pleasure to be here. I'm going to talk for a little bit about some of the implications of Tuesday on healthcare reform to give a sense of context of what this means in the short term and in the long term for the Affordable Care Act, the Reform Act that was passed last March. Obviously, there is pretty much of a split in this country on their view of this health care reform initiative. Let me give you sort of an opening statistic here, I think, to provide some context for why that might be. I remember 2 or 3 years ago, well, 3 years ago now, when I was doing some work with the Congress as they were gearing up to deal with health care reform. One of the things that I tried to point out was a very simple fact about the last midterm election. And that simple fact was, in the last midterm election, 96% of people who voted had health insurance. And the issue that they're focusing on in the voting public with health reform, their expectations of what they were hoping to see, was they wanted to make sure that their health insurance cost less, that their premiums went up at a slower rate, that they could keep the coverage that they had if they liked it. But certainly there was a big concern in the voting public about cost containment. I think if you roll forward over the last couple of years with the reform debate, virtually all the discussion was on a major element of healthcare reform that's always been out there, covering the uninsured. and really changing the nature of how competition in the insurance market works. And many believe that we have to move to universal coverage to really change the whole way that competition in the private health insurance market does indeed work. But I think that the frustration for many was that their expectations about what was going to come out of health care reform wasn't completely filled. Yes, they passed the universal coverage bill, very important, but there was ongoing concern about did we really deal with the issue around health care costs. And so that's, I think, one lingering aspect of this going into the election that people were concerned about. If you think about the takeaways from this as of Wednesday morning, I'll just sort of give you 3 points that I picked up from the exit polls when they asked voters about what drove their votes and what their thinking was. Yes, there's some frustration about the role of government, the amount of spending in the federal budget. But if you look at the data and ask voters what was a major concern about why you're voting, what drove your vote, it was on the economy and jobs. 62% of those in the exit polls said that the economy and jobs were issue number one that drove their vote and why they came to vote. 19%, a far distant second, was the issue and concern over health care. So I think to read too much into this in terms of a strong overreaching mandate on health care is probably misreading the exit polls. I think that the public is concerned about the unemployment rate. They're concerned about jobs. They're concerned about foreclosures. So they're basically, I think, saying to the Congress, you've spent 2 or 3 years focusing on health care. We need to really make sure that going forward that we focus on jobs and the economy. The second takeaway I had was 34 Democrats in the Congress voted against the Affordable Care Act. So they voted with Republicans, did not vote with the president on this. Half of them lost. So simply voting and running on voting against health care, at least in this election, didn't shelter a good number of Democrats who voted against the bill. And the third one, that's I think an important one, that just tells you how sort of split the country is on the issue of health care, is that they asked in the exit polls, what do you want the Congress to do on health care? Half of them said, just under half, about 48% said repeal it. The other half said build on it or keep it as it is. So we're going into a situation now where basically you have a 50-50 split in the voting public about what they want the Congress to do. If you think about what's going to happen in the near term on health care, let me just give you sort of my sense of 2 or 3 things that will happen. The Congress will come back in November 15th. They've got to do a couple of things right off the bat. They'll have to deal with issues around the extending the Bush tax cuts, which expire in January. They'll have to deal with fixing the Medicare physician payment formula. If they don't fix that when they come back as of December 1st, payments to physicians in the Medicare program will go down by 21.5%. So obviously they're not going to let that happen. So they'll come back and work on that. But most of the real work in terms of the rhetoric and semantics about reform will start in January. You've already heard out of the Republican leaders' remarks and others in the House that the first 2 pieces of legislation that they're going to put forward, H.R. 1 will be a bill to repeal the Affordable Care Act. And in fact, soon-to-be Leader Boehner has laid out sort of what I call the 4D strategy. They are going to disrupt, discredit, defund, and destroy the Affordable Care Act. So you can already see this is gearing up for quite an entertaining winter in the Congress between the new members of Congress and the administration on health care. There's some more immediate things, though, that are going to happen, and let's forget Washington for a minute and focus on the states. While most of the attention when we talk about health care really focuses on D.C., the reality is that most of the implementation, the key decisions, about how to implement health care reform are going to be done at the state level. So the states have an opportunity, if they want, to play a major role in reforming and redesigning how we prevent health care, how we deliver health care to chronically ill patients, how you pay for health care, by restructuring the health insurance market for individuals and small groups through what are known as health insurance exchanges, big supermarkets that make a variety of health plans available that people can shop for. And states have the opportunity to set certain rules and expectations about the plans that are offering their services through the exchanges. So the state of Ohio, with this change of leadership, has a decision to make about whether they want to design the exchanges here in Ohio, or whether or not you want Washington, D.C. to design it for you. So that's something that has to happen right off the bat. So even though there's going to be a lot of discussion in Congress about defunding health care and about rolling back the Reform Act, the reality is that at least until 2012, that won't happen. The votes are not in the Senate to do it. Remember, the Democrats retain control of the Senate. They have at least 52 votes there. And as we well remember from health care, you can't do anything to move a piece of legislation unless you have 60 votes. And there's not 60 votes in the Senate really to do anything. So the House will pass a repeal piece of legislation. It'll go to the Senate and die, and that'll be it. So what do we do for step two? Well, step two is going to place a substitute piece of legislation that retains a lot of what's in the Affordable Care Act, but put other provisions in that the Republican leadership is interested in, primarily issues around medical malpractice reform and other types of reform proposals. Again, that will likely pass the House, will go to the Senate, and will die. So Act 3. So where else do they go? And this is really where I think most of the real attention legislatively is going to be spent on is Act 3. That goes back to my 4D strategy of disrupt, discredit, defund, and destroy. There is an opportunity, I think, for the Republicans, and I think that they will do this, to go after some of the more minor pieces of the legislation. Remember, the guts of the legislation really is a requirement for people to have insurance. I think the dilemma is that by trying to sort of pick bits and pieces of this legislation out and recreate it, it's very difficult to do. And let me give you just a framework of why I think it's so difficult to do this. Really, healthcare reform was attempting to do three things: find ways to control the growth in healthcare spending, move to universal coverage, and reform the insurance rules. And those insurance rules, as you remember, that are going to be changing in 2014, is that in the individual and small group market, the ability to deny people coverage based on pre-existing conditions is eliminated. You have to basically, for people who want to buy a policy, you have to offer it. If people want to renew it, you have to renew it. So those insurance reforms of eliminating pre-existing conditions, moving to guarantee issue, moving to guarantee renewability was a central part of what happened in the reform effort. The interrelatedness of this comes from the fact that you can't really do that unless you have everybody covered, or a requirement for people to have insurance. Right? So you can't have one without the other. It would be sort of akin to saying that you don't have to have coverage, but anytime you want to buy it, a health insurance company would have to offer it to you, no matter what. So it'd be sort of akin to having a house. The house catches fire, and then you call your broker and you want to buy fire insurance for your house. So those provisions go hand in hand. So if you don't have the mandate, if you don't have the requirement for people to have coverage, you can't have the insurance reforms. So what that really means is that going forward, if this ever did unravel, we really would be largely back to where we were, really where we are today, that would allow companies to deny coverage depending on the state you're in based on pre-existing conditions and so on. It's a way to protect insurance companies from people signing up for coverage when they're sick. So those things are coupled. The other thing that's coupled in this that we're going to have to do some thinking about is cost containment. In today's health insurance market, largely in the small and individual group market, a lot of competition is driven by risk selection, the ability to find healthy books of business and drop less healthy books of business. So having a good actuarial underwriting is a very effective way of making sure that you have a healthy book of business and a healthy bottom line. Well, again, as you remember, the Affordable Care Act would disallow that. So health plans that are now competing with each other in the health insurance exchanges can no longer compete based on risk selection. They really were going to have to compete based on quality, outcomes, and the cost of their health plan. They're going to have to compete on the metrics we really want them to compete on, which is on outcomes and price, not necessarily on underwriting. So again, the law as it sits together and packaged has the opportunity to really fundamentally transform competition in the insurance market and how it operates. So I just wanted to give you a picture is that there may be pieces of this that we don't like. The problem is that to move towards a competitive marketplace that really does focus on premium and quality competition, to eliminate some of the discriminatory insurance rules, does have a prerequisite that you move towards universal coverage. Now, this was a condition that the health insurance industry laid out up front. They were willing to play in the healthcare reform initiative. So the trade association, America's Health Insurance Plans, AHIP, was very active in the discussions right up front on healthcare reform. And they said that we'll agree to get rid of these discriminatory insurance rating rules, but only if there's a mandate to buy coverage. If there's not a mandate to buy coverage, then we can't agree to eliminating these discriminatory insurance rules. So going forward, this is going to be very difficult, I think, to keep all three of these things together in any type of a revised version of it, because they're all interrelated. They're all intertwined. So the third thing, what are they going to do? Act 3. There's a variety of provisions in the bill that I think you can get both Democratic and Republican support to modify or repeal, maybe not the core components, but there are some pieces. Number one, there's a provision in there that would require small companies, when they do business with a vendor or a consultant, and if they buy more than $600 worth of goods and services, that small business would have to issue a 1099. Now, that raised a lot of money. That raised $17 billion in new revenue as part of the bill. The dilemma is it's very burdensome for small businesses to do this. And so I think there's a lot of interest in repealing that. The problem is in Congress is that we work under what is known pay-as-you-go rules. So if you change a piece of legislation, it can't add to the deficit. So if you repeal the 1099 provision, you'd lose $17 billion in revenue that's already in the budget baseline. So if it's repealed, you've got to find $17 billion in spending cuts or new revenues to pay for it. So every one of these provisions that we're going to be talking about in terms of making changes are all going to have to be paid for. Just take the broad repeal. The other reason why it couldn't really, I don't think, realistically pass through the whole Congress is that whether you believe it or not, in terms of the numbers, in Washington, the only thing that really matters is what the Congressional Budget Office says. Everybody else can have their own opinions about whether the health care reform bill increases the deficit, decreases the deficit. It doesn't matter in terms of the congressional rulemaking process. The only thing that matters is what the Congressional Budget Office says about what the bill cost and what revenues are raised and what impact it has on the deficit. The CBO estimated over the next 10 years that the health care reform bill would reduce the deficit by $124 billion. So if you repeal the health care reform bill, the deficit goes up by $124 billion. And to pass it through the Congress, you got to pay for it. So you'd have to find $124 billion in spending cuts or new revenues to repeal the bill. So you can see that the roadblocks and the difficulties going forth operationally, in reality. There's going to be a tremendous amount of rhetoric about this. Remember that Wednesday morning is the first day of the 2012 presidential race. So that's what the debate is going to be over the next 2 years. 10, just it's going to be like that forever. This is going to be a setup for positioning candidates to their bases for the 2012 presidential election. So where can they make some changes? As I mentioned, the 1099 provision, you'll see a piece of legislation coming out. I think that will be repealed. But they're going to have to find a pay for. They're going to have to find some way to find $17 billion in offsetting revenues. There's another aspect in here that would fund comparative effectiveness research. Research that would compare different ways of treating disease, compare different ways of preventing disease. It deals with issues around different types of drugs, devices, and approaches, surgical, medical, medication therapy. What's the most effective in terms of generating better outcomes? And what do they cost? There was a lot of discussion in the Congress and concern that type of research that provides information to clinicians and the families about treatment options and the relative effectiveness would lead to rationing. The payers would use that information to ration care and deny people access to certain types of procedures. So in the legislation, we have research that's funded, but it explicitly says in the legislation that the results from the research can't be used to ration care. Well, I'm not quite sure what you do with this research or how it's played out, but it explicitly says it can't be used to ration care. Now, obviously, almost anything you do in medicine, in terms of a clinical decision that a provider makes, could be argued is rationing care. Clinical decision making in and of itself. So that's an area that's, I think, ripe for repeal. It would be, I think, a shame because we have so little evidence base on what we do in medicine and what works, under what circumstances, for what populations. Not to move down that road and provide the information to the medical community, families about different ways of treating people is a shame. But we got caught in this rhetorical discussion about rationing. It started with the death panels. How many people remember the death panels? That was one of the goofiest arguments I've ever heard. And the problem was that was a serious discussion that happens every day in a physician's office, medical centers, for patients that are either terminally ill or very sick, about working with their provider, working with their families about what options are available going forward. How aggressive do we want to be? What are the likely outcomes of aggressive treatments, not aggressive treatments? What expectation does it have on quality of life, how long I might live, and so on? Legitimate discussions that you'd want to have with your provider, you'd want to have with your family. Ironically, what the bill did, and it was proposed by my senator, a Republican senator, Saxby Chambliss, that physicians could simply bill to have that discussion in Medicare. They can't today. That was a proposal that would allow physicians to actually have the discussion, spend the time with the family and the patient, talk through different types of treatment options, initiated by the patient, not by the physician. And if that discussion happened about treatment options, it would allow the physician to bill Medicare for having that discussion. So you can see that this issue of rationing and sort of how it's positioned is very, very politically sensitive. That was dropped from the legislation very quickly because there was, once it was out of the box that we had death panels and bureaucrats making thumbs up and thumbs down decisions about people living or dying, it had no political legitimacy left as part of the legislation. But that's going to be on the blocks too. I think you'll see an effort to defund that. There's another group, and I'll just sort of end with this. It's called the Independent Payment Advisory Board. This is one where Congress basically says we're not capable of finding ways to control the growth of Medicare and Medicaid spending. If those spending rates grow faster than we want them to, we're going to have this new independent board that's going to make specific recommendations about how to reduce spending in those programs. And unless the Congress acts, they go into law. So they basically ceded their legislative authority to this Independent Payment Advisory Board to make recommendations that go into law unless the Congress acts. Now, the Congress can say, no, we don't like those recommendations, but they'd have to replace them with their own. So I think you'll see some efforts to pull back on some of those things that are peripheral to the core of what was passed, the insurance reforms, the requirement to buy coverage, and so on, at least for the next 2 years. Let me end on a positive note here. Otherwise, the election was grueling, and the rhetoric coming out of Washington in terms of what's going to happen to the health care reform bill and so on, it's almost like I want to hide under my bed for the next 2 years. I think there are some things that they can work on that actually at the end of the day may be fundamentally more important in terms of how people get their health care provided and delivered than a lot of the political positioning of what's going on in Washington. And that's on two issues. One is that we know in this country we've got a real problem with childhood and adult rising rates of obesity. 34% of the population considered obese today, 17% just in 1985. It's a major driver of rising healthcare spending. We can find bipartisan ways and effective ways to intervene and do a better job of turning those curves around. School-based interventions, workplace interventions, community-based interventions. Those are areas that I think we can work on and work on together. Those aren't Republican or Democratic issues. No, those are just good public health issues that everybody should work on together. And the second area is on the management of patients with chronic health care conditions. 75% of what we spend in this country is linked to patients with chronic diseases. So just to give you a profile, the typical patient where all the money is bottled up in health care is somebody who's likely overweight or obese, is a hypertensive diabetic with bad cholesterol, bad triglycerides, back problems, arthritis, pulmonary disease, asthma, and they're depressed. That's our patient. And on any given day, that's half of those conditions are me. So that's the patient. And that patient in our healthcare system today is probably seeing 2 primary care docs, multiple specialists, is on 10 to 15 different medications. And there's no team-based approach to work with that patient. There's little coordination. There's very little knowledge across physicians of what's going on. We can do a much better job in terms of working with that patient and really doing primary team-based care to make sure that that patient stays healthy, stays out of the hospital, is not readmitted to the hospital unnecessarily. That just deals with the delivery system infrastructure in this country that I think is largely dysfunctional and is largely broken, largely because of how we pay for health care in this country. We have the system that we incent to have. We have the system that we pay for. So we need to change some of those payment rules, build a primary care delivery system infrastructure, and be more aggressive and thoughtful about how we prevent disease in the first place. To me, those are major elements of healthcare reform. If you take a step back and wonder, what are we trying to do here? We're trying to improve the health of the public. We're trying to make sure that when people get sick, we have effective ways of working with them to keep them healthy. Those are areas I think that in the next couple of years that I'm going to be encouraging the Congress to work on. They're not partisan issues. They're not ideological issues. To me, they're just good, common sense public health in healthcare issues. So hopefully I'll leave that on a good note, and if we can change the tenor of the discussion away from, yes, you got to go and rouse up the base. You won, so you got to go ahead and do the 4 Ds. But I'm hoping, realistically, in the back rooms, that they do roll up their sleeves and find some common grounds on areas that really, really are important to most people in this country. So thanks, and I'm going to stop here and open it up for questions.
Today at the City Club of Cleveland, we are listening to a Friday forum featuring Dr. Kenneth Thorpe, Robert W. Woodruff Professor and Chair of the Department of Health Policy and Management at the Rollins School of Public Health at Emory University. We will return to our speaker momentarily for the traditional City Club questions. We encourage to start formulating your questions now and remind you that your questions should be brief and to the point. We remind you that members and guests alike are welcome to attend City Club forums and hope that everyone listening will join the City Club and become active in our ongoing civic dialogue. Please visit our website, cityclub.org, to see a full schedule of our upcoming programs. We welcome all of you here and those listening to WCPN 90.3 FM, WCLV, WTAM, or one of the many radio stations across the country. Our television broadcast partner is WVIZ PBS IdeaStream. Television broadcasts of the City Club are made possible by Cleveland State University and PNC. Our live webcast is supported by the University of Akron. If you wish to make reservations or order a CD or DVD of today's program, please call 1-888-223-6786 or 216-621-0082. Today is the annual Forum on Progress made possible by a special gift from the Progressive Corporation. Today's program is also made possible through a partnership with the Brian and Sidney Murphy Lectureship. We welcome guests today at tables hosted by Baker and Hostetler, the Center for Health Research, Medical Mutual of Ohio, the Metro Health Foundation, and the Metro Health System. Thank you all for your support. We are also pleased to host students at our forum today who are here as part of our City Club student program. Participation of these students is made possible by a generous contribution from the Jeffrey David Epstein Memorial Student Fund. With us today are students from Cleveland School of Science and Medicine. Will the students please stand and be recognized? Thank you for joining us today. Now we would like to return to our speaker for our traditional City Club question and answer period. We welcome questions from everyone, including guests. Holding the microphones today are City Club Development Director Cheryl Helden and Program Director Carrie Miller. First question, please.
Professor Thorpe, I'm certainly glad to hear you say that because of the Senate that the health care bill will not be repealed. I should think that President Obama could certainly veto it if it did happen to be, and it could never be overridden, which brings me to the point of another thing I think you broached on, the tax cuts. And I certainly hope that President Obama does not show a complete lack of character and principles by not going along with repealing the tax cuts for the 2%.
Dr. Thorpe?
Yes.
You spoke about the challenges involved in having insurance coverage for all Americans and all the complexities that are involved. Those of us who are over 65 find that we automatically, at a slight cost for a supplement, are able to have complete insurance, both for our physicians, for hospitals, and all goes along with it. What is your feeling about having that program expanded to cover all Americans? And while there could be immediate problems with the current composition to be of the Senate and the House, do you think there's some future for having the Medicare program expanded with its basic simplicity to all Americans?
Well, it's certainly a thoughtful idea and suggestion. It's one that's been on the table for years in the Congress. I think the political dilemma that they face in the Senate is that this was considered in the Finance Committee. I think Senator Baucus quickly found that in the entire Senate he probably had a handful of votes to do it. And they just had to make a political decision that realistically didn't have any chance of passing, that they could have spent a lot of time discussing and designing a proposal that is thoughtful as it would be, as simple as it would be, administratively less complicated it would be. The votes just weren't there. So I think, ironically, the semantics around healthcare reform, around government-run healthcare, the irony is that the bill that passed is all private health insurance. So the expansion is all built on the existing private health insurance plan. So it's one of those things that, I guess my counsel is that the Republicans are going to call it government-run no matter what. If it's Medicare expansion, if it's private health insurance expansion, it's not going to really matter. I would like to see them at least put it into the mix for discussion. But the reality is that the votes just weren't there.
Thanks for your presentation, Dr. Thorpe. I was encouraged that you feel there'll be bipartisan support for the public health initiatives you mentioned, school-based, community-based interventions, yet I have some concerns that the DD fund issue is still out there. Prior to the midterms, there was an attempt to a run made on Johann's amendment made on the Prevention and Public Health Fund. I think it came up only 5 votes short. Do you think post midterm that there may be efforts to still whittle away at the edges, particularly on a fund that would have, as you indicate, some bipartisan support for those efforts?
Right. As part of the reform effort, there was a Prevention and Public Health Trust Fund. Over the next 10 years, it would spend $15 billion on building evidence-based community prevention programs designed to improve the health of communities, kids, and at the end of the day, save money. I think the political dilemma with it is that it looks like a big slush fund. The HHS, I don't think to date, has signaled effectively for my money how they're going to spend the money. I think if they made the case that said we're going to make investments with this money in things that have been shown to work. So we've been talking the last day or so here about a program called the Diabetes Prevention Program. A lifestyle intervention that reduces the incidence of diabetes by 58%. That works. We should invest in that and do that nationally in all the communities throughout the country to make sure that people who want to have a program that works and working with their employers to do so have it. So the answer to your question is that going to be back on the pay-for list? Absolutely. I wouldn't be surprised to see that as a pay-for to repeal the 1099 loss of revenue. It probably would pass the House. Whether or not you could hold forth with the 52 votes in the Senate on that is a good guess. So I think they're going to have to do some vote counting. But there's no question that that's an easy target that the Republicans will go after to pay for some of these things they want to repeal.
Dr. Thorpe, thank you very much for your presentation. Here in Ohio, we have mandated automobile insurance purchase. We have slightly less than 85% of the people in the state of Ohio that buy insurance, even with that law. My question to you is, given that kind of a context, what realistic, practical way do you think we will get mandated health insurance to be at a higher number than that? And why would we even want to do that when on a voluntary system that we have today, we're more than 85% covered in this country? And then I guess the other part of that question is, why would we do it from a constitutional standpoint? Seems to me that that's very unconstitutional to require people to mandate buy something on a private basis.
Well, sure. No, thanks for the question. On the mandate side, Again, this goes back to this notion of, are we going to do insurance reforms or not do insurance reforms? So this was a huge upfront decision that said we're going to do insurance reforms, eliminate pre-existing conditions and so on, but you've got to do the mandate. In the bill, the other part of the discussion was, what are the penalties? It's the same thing with the insurance, automobile insurance market. What are the penalties associated with not having car insurance? That was a huge debate in the reform effort that says, what happens with people that don't want to buy it? Well, then there's a penalty. So you just have to pay a penalty to the IRS. The trade-off is that on the one hand, you didn't want to make it too big because families couldn't perhaps afford it. On the other hand, if you make it too small, people won't buy coverage. They'll pay a penalty, but when they get sick, they'll go buy coverage. All right, so that's the problem. And the Congressional Budget Office estimated that by 2020, we'll have 55 million people that don't have health insurance, that 32 million of them would buy it, and the remaining 20 million would pay the penalty. The reason is that in the first year of the plan, 2014, if you don't buy coverage, the penalty is $95. So, again, they were in this dilemma about not making it punitive, but on the other hand, if it's not a real financial penalty, then people are just going to pay the fine, and when they get sick, then they'll go buy the coverage. So, that's an aspect of it that probably wasn't a good outcome. The insurance industry was very upset with that provision because there was too much leakage out of the system. They wanted numbers that were basically not 32 million people covered, but 45, 50 million people covered, and so they were advocating to make sure that the penalty was sufficient so that we really have a bigger, broader risk pool of people in what we're providing. But it didn't turn out that way, and it was probably, to me, in the design of it, is one of the things that's troubling. It's a problem. On the constitutionality part of it, I'll have to let the courts play that one out. That's certainly not an area of expertise of mine.
Dr. Thorpe, thank you for being here. I am part of a consortium of statewide health-focused funders in Ohio, and one of our efforts that we're struggling with really is identifying the one or two top things that we can get behind collectively to ensure that healthcare reform, whatever it looks like, rolls out effectively in Ohio. So I would ask your advice as to what you think the one or two most important things we can support that would make that happen.
Oh, it's a good question, and we were talking about this with my friends at Case Western and Metro Health over the last day or so. One of the areas I think that there's a real opportunity is really building a delivery system in this state that's really effective in providing team-based ongoing care for chronically ill patients. And in the legislation, it provides financial incentives for Medicaid programs to build up what are called community health teams, teams of nurses, nurse practitioners, pharmacists, other primary care providers that would work with patients to execute whatever care plan they have, to keep them out of the hospital, to do transitional work as they go in and out of hospitals or nursing homes, do medication management and reconciliation, to make sure that they're filling and refilling their prescriptions, that everything's moving on the right track. That's a system that in most of the country doesn't exist. So the health reform bill basically said if the state of Ohio in Medicaid does this, builds this particular model, which has been shown to be very effective in improving clinical outcomes, reducing costs, that the state would get a 90% match. So they'll get an enhanced match to do it. So that's one opportunity there. Working with the private sector, too, to have them engage in those teams. The state of Vermont does this across the board. All payers use that model, the private sector, state employees, Medicare, Medicaid. So I think that's an area where we found that there's a lot of opportunity for collaborating. A second opportunity is nationally we're starting to see this diabetes prevention program being put in different communities, mostly run by YMCAs, but they could be run by other community-based organizations. United Health Group has partnered with the YMCA's to do this and make it part of their benefit offering because it works. It's an effective program. Now, that's something that I think, again, you could work with the business community here to provide sort of workplace incentives to get people to use this particular program, opportunities for some federal funding to help get them up and running, do the training and certification of people who are doing the lifestyle programs, and so on. So those are two areas that, regardless of the politics, you know, as I've been saying, those aren't political issues. Those are just doing the right thing in preventing disease and working with people that are chronically ill. So I would just encourage you to try to find areas that are important, that go to the heart of the problem in terms of quality and cost, but aren't ideological. And those are two, I think, examples that you could spend time on.
Thank you. Dr. Thorpe, you talked about the, in your closing remarks, about a renewed focus on primary care, chronic disease management, and the need for innovative reimbursement models. The healthcare reform bill talks about a concept called accountable care organizations. Can you discuss how the ACO addresses those topics as well as the challenges in implementing the ACOs moving forward?
Well, sure. So this will, I'll try not to get into too much detail with this. I think that the Congress got very enamored with this whole Accountable Care Organization Act concept because they had big system after big system come in and testify. Geisinger, Marshfield Clinic, Cleveland Clinic was there as well, Intermountain Healthcare, Kaiser Health Plan from Oakland, Puget Sound, big integrated multidisciplinary group practices. And they had a common feature that under one roof there's the hospital, physicians, primary care providers, care coordinators, nurse practitioners that really did team-based care. They all do it differently, but that's sort of the general concept. So this notion of the accountable care organizations is to try to replicate those in a delivery system that's very disorganized. Most primary care physicians still work independently in groups of 4 and 5, those ones that haven't already been bought out. So the ones that are left standing. So everybody is pretty much working independently. And the idea is how do we get these providers, specialists, primary care docs, hospitals, care coordinators to work as a team? And the way to do it is perhaps not have them organized like Geisinger, but have them contractually linked. So there's a contract where they would be responsible for taking care of a panel of patients in their practice. So to participate, you have to have 5,000 Medicare patients that you are responsible for the cost of their care and you're responsible for the quality of their care. And if you do a good job on both, there's some opportunity to share in the savings. So that's the concept. The regulations about how it's going to actually play out will come early next year. So the Department of Health and Human Services is currently working through what are the quality measures we want to look at, how does a shared savings work, what criteria do we want to establish for ACOs to get into the market, what legal impediments are there to current law to have those providers collectively work together. So there's a whole bunch of legal challenges and definitional challenges, but I think that there's a lot of interest in building that model that really does do integrated team-based care.
Yeah, outside of sicking Gary Musselman on them, what would you do with hypochondriacs? They'll just...
Well, I'd bill them. I would bill them. So other than that, I don't know what I'd do with hypochondriacs.
If you have free medicine, the type of thing you're talking about, how are you going to dig them out? How are you going to build them?
Well, again, I'm not quite sure the question is. I mean, the plan doesn't have free medicine. What the plan is that you're required to buy Aetna, Blue Cross, Cigna, a private health insurance plan.
I wanted to ask you a little more about the 1099 thing you referred to. First of all, why is this part of the health care bill? And secondly, why is there a revenue loss if you eliminate the 1099 reporting requirement?
Both good questions. Remember again that the health care bill over the next 10 years, was going to cost something a little over $900 billion over 10 years. For the health care bill to pass, they had to find $900 billion in new revenue and or savings in existing programs. So that's a lot of money to find. So the reason it's in there purely is that it was a new source of revenue to help pay for the bill. A lot of what the IRS was telling them is that there's a lot of unreported income coming to vendors from small businesses that weren't being reported on 1099s that would now have to be reported on a 1099 form. And that was going to raise $17 billion in new money. So that's built in right now to law. So if you repeal the law, you've got to replace the $17 billion in lost revenue. It makes no sense in the context of doing health reform, right? It was just simply there as one of the many things that they needed to have in there to help pay for the cost of the bill.
Thanks for coming. Thinking about the damage the new Congress could possibly do, I don't think you really talked about defunding if they refuse to fund certain portions of it. Could you explore that a little bit?
Well, they can, in terms of defunding, the easiest place they can do is go after what are known as discretionary expenditures, things that Congress has to annually appropriate. So really for the IRS and HHS to implement the bill, they are going to need more staff. They're going to need a little bit more resources because implementing this is a very person-intensive effort. So they could say, we're not going to appropriate the money. So you're not going to have the people. The problem is that the law is still there. By law, they have to move the statutes forward. They have to go into the Federal Register and lay the regulations out. So I think sort of the cynical part of that to me is that, yes, you can go ahead and try to defund pieces of it like that and not give them the resources to implement it. And then when they don't implement it, you're going to yell at them for being sloppy and not implementing the regulations. So it's, again, that's why I said the next 2 years is just going to be this, I wish I could just fast forward to 2012 somehow, because it's going to be like that. It's just going to be a very difficult place to be. The hearings, the oversight, the discussion about the funding provisions of it, passing the repeal piece. Again, this is all positioning and making the case in 2012 for a Republican president to come in and really do repeal it.
Americans don't like to look beyond our shores for models. We roundly denounce the Canadian and the English systems of health care provision. However, there do seem to be some working systems out there, Spain, France, Germany, that provide pretty good health care to the entire population at far less cost than we do. Are there particular aspects of those systems that you would like to see implemented here?
Well, that's a very good question. And you're right. I mean, the European systems, if you look at any objective outcome, longevity, quality of life measures, infant mortality rates, we're not the best on any one of those. Each of those countries does it differently. Some have something that looks like Medicare for all, so the National Health Service. The Germans and the Swiss use private health insurance. They're just not-for-profit mutual companies to provide insurance. The common feature of many of those systems that do a good job at lower cost is that they've got a very sophisticated prevention and primary care system that really delivers effectively up front in preventing disease and working on the primary care side to keep patients healthy. We have sort of the exact flip of this. We've built an incredible tertiary care infrastructure, which is very good. But we've underinvested in a primary care infrastructure where at the end of the day, if you're looking at mortality and morbidity indicators, those are primarily determined by preventable lifestyle interventions and primary care. So I think that, going forward, if we invest more heavily in prevention and primary care, that will make a big difference in terms of improving both costs, but also improving a lot of the morbidity and mortality indicators that we don't do as well as we should on.
Today at the City Club of Cleveland, we have been listening to Dr. Kenneth Thorpe, Robert W. Woodruff Professor and Chair of the Department of Health Policy and Management at the Rollins School of Public Health at Emory University. Thank you, Dr. Thorpe. Thank you, ladies and gentlemen. This forum is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.